Hey, CE Impact subscribers, welcome to the GameChangers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. With the steady stream of new drug approvals, it's essential for pharmacists to stay informed about what's entering the market. In this episode, we'll review a handful of recent approvals and highlight information to help you support safe, evidence-based care. It's great to have our resident new medication expert, Joe Strain. He's done this now. Gosh, I've attended 4 or 5 of these with you, I think, now total. I know this has kind of become your thing, which is great. So Joe Strain, welcome. Thanks for being back with us. And for those of our listeners who haven't had a chance to meet you or hear one of your sessions yet, go ahead and take a couple minutes to tell us a little bit about yourself and your practice site and maybe why you are passionate about new meds.
Well, thanks for having me, Josh. I appreciate it. So I guess, so I'll tell you about where I'm at now. I've been working for South Dakota State University College of Pharmacy and Allied Health Professions for 22 years now. So I joined the faculty there just a number of years ago. But my practice site has been at Monument Health, Rapid City Hospital for the last 22 years as well. I primarily work with the internal medicine hospitalist program, but also a few months out of the year we'll work with our infectious disease service as well. My practice is kind of dictated a little bit based on the students I have and what rotation they're kind of assigned to. But I have a couple great groups to work with there at the hospital that are they value teaching, they value having students around, and really value a collaborative practice. So it's really a kind of an ideal practice environment for my students to see and learn from. As far as new drugs go, it's kind of basically 22 years ago, our state association asked me to give a new drug update, and as being a new junior faculty, I said, sure. Why not? Well, 22 years later, it became it's still an annual tradition. So I've been back every year, and so it's certainly nice to be able to share this on a kind of another broad platform, I guess, if you will, to kind of share some of the information and just to keep up with new drugs. I always say there's nothing. I always feel a little awkward if someone asks me about a medication I have never heard of it.
Same. Especially, or if you're watching TV and you see a new drug ad and you're like, oh my goodness, I don't even know what that is. Exactly. Where have I been? Yeah. So yeah, absolutely.
And patients are the same way, right? Because they get that direct to consumer advertising. So they're going to ask you a question. Yep. And maybe it's in a lot of these drugs I may never even use in my practice site, but you still get questions from whether it's, family members, friends, just they see these ads and they want to know about medication. So at least it's a good, it's always better if you have at least heard of it and have an idea what it's about.
Exactly. If you can at least say it's for XYZ, so yeah, absolutely. So just to set the stage, thanks again. Let me just not forget to say that. Thanks again for joining us. We really appreciate it. But as to set the stage, let's just kind of quickly review. Obviously, the FDA has a hand in medication approvals, and that's kind of, the process that we go through. It can be many, many years sometimes for a new drug to make it to market. There are some abbreviated applications, and some things can come to market a little bit faster than others. But for the most part, it is a multi-year process for something to come on the market. So that's also another reason to highlight them, is because they've made it so far, and it's even if it's a short audience that it's going to reach, it is for a significant reason, like the medication has come out for a significant reason. So, so in that being said, Joe, tell us a little bit about how you chose the medications that we're going to talk about today. So it looks like we're going to highlight maybe, I don't know, a handful, 10 or so. So how did you choose which medications we're going to review today?
Yeah, so if you look at kind of the number of approvals kind of on an annual basis, over the last 10 years, it's been kind of between 45 and 50 on average as far as the number of annual approvals. So you got to kind of narrow that list down. We're not going to talk about 50 medications today. We don't have time for that, obviously. But when I look at kind of giving these new drug updates, in looking at the list of drugs that have come out, a number of them are for very specialized conditions, very rare diseases that you're just probably unlikely to come across. And there may not be as much direct-to-consumer advertising as some of those medications. So what I've tried to pick out is drugs that would target kind of a very common condition. So more likely to have a wider audience as far as what it's going to be marketed to, more likely to come across it no matter your practice setting. I've also looked at drugs that maybe have a little bit of a unique mechanism. And so how is it different than the other agents that would currently are on the market for that condition.
Mm-hmm.
And then also occasionally you'll get a drug that's approved that is a different dosage form. Let's say this whole class of medications has been all IV medications, and now we have an oral medication available. So I think highlighting that is valuable too, just to know there's an alternative route within that
that's
class.
great. That's great. So like you said, there was, maybe 40, 50 new drugs in the last several months. And so, like I mentioned, we've kind of pulled out, let's see here, 2, 4, 6, almost 10 that we're going to try to highlight today. And Joe is going to take the lead here, obviously, because he is the expert in this space. But basically, just for each one, you're going to kind of tell a little bit about the drug, the indication, like why did it come to market, who is it targeting, where might we see its use being occurring in practice, and then just a little bit about some of the nuances of each medication, right? So if there's something weird that we need to be sure we're counseling on, or if there's some kind of weird dosing thing, or if there's an odd pharmacokinetic bioavailability or something like that, I'm sure that's what your plans are, is to kind of highlight the nuances and oddities of the different drugs, correct?
Absolutely.
Perfect.
This isn't necessarily going to make you an expert on any of these medications, this podcast,
Sure.
but it's going to make you familiar, at least have heard of them. And then if it's something that piques your interest as far as, wow, I could see this impacting my practice, or at least I expect questions about this, then you're going to take a deeper dive.
Absolutely.
Yeah.
Absolutely.
But we'll at least get you the highlights and give you a feel for where it's at. And then I'll also probably comment on, we're going to stick with on-label, discussion today.
Sure.
But there's a couple situations where I will mention maybe some studies ongoing for some other things that you might want to keep an eye on down the road.
Great. Yeah, that's great.
I think that's helpful.
That's perfect. That sounds good. Well, I will yield the floor to you and take it away with the first drug, and let's go from there.
Yeah, so we're going to start off in the ID world. That's obviously a practice area of mine. So we're going to start off with talking about a couple of new antibiotics, and they're actually both approved for urinary tract infections. And so we know that urinary tract infections are very common. And so our first drug we'll talk about here is gepotidacin, and that's going to be marketed under the brand name Blujepa. And so this one is approved for uncomplicated UTIs in female patients that are at least 12 years of age or older. And it's going to cover all kind of the routine urinary pathogens that you'd expect, like E. coli, Klebsiella. It also covers Citrobacter, and then Staph saprophyticus, and then Enterococcus faecalis. So organisms that you kind of expect to cause UTIs. Now, from a pharmacology standpoint, this is going to work on inhibiting topoisomerase 2 and topoisomerase 4, thus blocking DNA replication. And so this is if this is a mechanism sounds familiar, it's because the quinolones work that way, right? But technically, it's targeting a different site on those enzymes. So it is acting at a different spot than the quinolones do on that enzyme to inhibit DNA replication. So it is different, and it's not considered a fluoroquinolone.
Okay.
Now, from a warning standpoint, things to watch out for, it does cause some QT prolongation. So if you do process, and dispense this, you're going to see some warnings about QT prolongation. Again, probably not a huge deal for most patients unless they're high risk or if they're on other medications that would cause QT prolongation. Then you might want to raise some awareness about that. The other thing about this drug is that it inhibits acetylcholinesterase. And so by increasing acetylcholine, essentially, you are going to potentially increase some muscarinic side effects. And when I think about that, I think like GI side effects. And, with a lot of antibiotics, we have GI side effects. And with this one, the incidence of diarrhea in the trials was around 16%. And it was compared to nitrofurantoin, and that was around 3%. So at least compared to nitrofurantoin in the trials we had, it did cause more diarrhea and so GI side effects. And some of that could potentially be attributed to that increased cholinergic activity.
Yeah, that makes sense. What you mentioned the potential kind of sort of comparison to fluoroquinolones, and I'm completely drawing a blank. But there was what was the major concern with some of the fluoroquinolones not too long ago, where I'm drawing a complete blank.
Yeah.
But
Well, there's a few different issues. I mean, they can cause QT prolongation as well. Then you have the tendon issues with that
tendon,
one.
yes, that's what I was thinking of. Yes.
Yeah.
So do we see a similarity with this, or is it completely targeted differently, and so it's not hitting that?
No, the only common side effect or warning that I saw with this in the quinolone was the QT prolongation.
QT. Okay.
It didn't have the concern about the aortic aneurysms, and that was another kind of a warning
that's right
as well. So, but
yeah, I was thinking of the tendon one. Now I thought it was something to do with a muscle or something, and so yeah, that is exactly what I was thinking. Okay,
yeah,
good to know.
None of that was reported in the trials anyway, so hopefully that's not the case. But again, some of that stuff we always kind of got to keep an eye on things and see how things evolve. But
exactly.
So far so good on that front. So.
Okay, sounds good. Go ahead. I interrupted you. Finish.
No, you're good. Any questions along the way, just please feel free to ask. I can try to clarify the best I can here.
Sure.
I just want to comment a little bit on efficacy with this medication. There was a couple of phase 3 trials done. Again, they were studying it against nitrofurantoin. Both drugs were used for 5 days of therapy. And one of the trials basically showed it to be non-inferior to nitrofurantoin, so just as good. But the other trial actually did show a little bit better outcomes in regard to symptom resolution and microbiologic cure with the gepotidacin than nitrofurantoin. So it at least works as well as nitrofurantoin, and one of the trials actually worked a little bit better. So.
Okay, that's good.
Yeah, and so just to kind of highlight the dosing of this, it's going to be 1,500 milligrams twice a day. It's going to come as 750 milligram tablets. So you're going to take 2 tablets twice a day, and then it's indicated for 5 days. That's how the studies were done. We still avoid it in severe like renal impairment, like creatinine clearance less than 30. That's probably kind of the one area where we tend not to want to use it in that population.
Okay.
But overall, again, it's another agent to add to the market. Now, if you think about it, do we have a lot of agents for uncomplicated UTIs that are pretty cheap? Yeah, we do. The question here is, what's this going to cost? This is expected to be out second half of 2025, which is where we're at right now, but we have not seen it formally released yet. So I don't have a specific price for you on this one as of yet. Obviously, that would be a potential barrier when you're talking about an agent for uncomplicated UTIs, when you're comparing it to things or other medications that have been around for years that are generic and very inexpensive, right? So
yeah. I think that was going to be my question is there something that really stands out that makes this shine differently? Like, would there be a contraindication on a cheaper medication or something that makes this one be like, okay, yeah, this is the new gold standard or anything? Or is it really just...
I don't think it'll be prime time for UTIs, but the one area where you want to keep an eye out, it's currently under review at the FDA for Neisseria gonorrhea as an oral option. And so the FDA is reviewing that data. I think they have a review date of December of this year. So just here in a few months, the decision will be made on that. And I'm not going to go into great detail on the data, but some of the preliminary stuff, I think there's optimism that this may eventually play a role for that condition. And there's really limited oral options in that regard. So I think this is one where I wanted to mention, stay tuned for more data coming with this medication, because that does have potential in that area. Yeah.
Okay. Great. That's great. Okay. Well, let's move on to the next one then.
Yeah, so the next one's also another agent approved for uncomplicated urinary tract infections, and this is sulopenem plus probenecid. So it's a combination tablet, or Linva is going to be the brand name. But again, if it sounds like a carbapenem, it's because it's very similar to the carbapenems. It's actually going to be termed a thiopenem, but it's still a penem. They've just substituted a sulfur molecule on one of the rings there. So, but it's being touted as being very similar to the carbapenems as far as kind of how it's structured, I guess, if you will.
Okay.
But a couple things to note with this. So the thought is, well, okay, now we have an oral carbapenem, right? And so is this going to be used as kind of a step-down therapy? But if you look at the labeling, it's only approved for uncomplicated UTIs caused by E. coli, Klebsiella, or Proteus in adult women with limited or no alternative oral options. So it's, again, pretty small market where you're stuck with, you don't have any other options for these specific bacteria. It's interesting in the labeling, they do specifically note that it is not indicated for complicated UTIs or as step-down therapy from IV treatment for those infections, or for complicated intra-abdominal infections or as step-down therapy. And the reason why is because there's specific data out there that did not meet the non-inferiority criteria compared to the IV ertapenem in those studies. So it's interesting when you see a drug that gets, you usually just see what it's labeled for. You don't always see
what it's not.
It's not used for.
Yeah, so that's interesting.
Yeah, so it's just not ready for kind of that role yet, at least based on the current data we have. Now we'll see what happens with research and development down the road, but I think that was the initial thought. But again, just want people to be aware that the current data that's out there did not support it in that role.
Interesting.
So,
okay.
They've combined it with probenecid, and we know probenecid will inhibit renal tubular transport, and so that's intended here to try to increase the levels of the sulopenem to make them therapeutic, and so that's why they had to combine it with probenecid to achieve those therapeutic levels. A couple things to note when you take this one: it has to be given with a high-fat meal to increase absorption. That is going to be critical. Otherwise, you're not going to get enough absorbed, and so that's going to be something to note. From a side effect warning standpoint, there's really not a lot new here. I mean, there's some things that go along with probenecid. We don't use probenecid a whole lot anymore, right? And so just thinking about drug interactions with that, because of all the things that would inhibit from a renal tubular transport system, if you did come across this medication down the road, you would run into some drug interactions with the probenecid part of it. But the sulopenem is very similar to our other beta-lactams, and so not a lot new there for warnings, if you will. But another oral antibiotic. So what do you expect for side effects? GI things. Diarrhea was more common in the clinical trials with the sulopenem compared to the other antibiotics it was studied against. And so that's something to be expected, I guess. About 10% of patients experience that.
Okay.
From an efficacy standpoint, just to highlight a couple trials, they studied it against amoxicillin and clavulanate, so Augmentin. Looked at both of them for 5 days. Basically showed it was non-inferior to Augmentin. Again, most of these patients just had E. coli UTIs. Again, these were uncomplicated UTIs. They also studied it against ciprofloxacin. They used the Cipro at a low dose, 250 BID for 3 days. In the overall population, they showed it to be non-inferior. There was a couple caveats of different arms they looked at where, so there's a little more involved with that trial. If you want to take a deeper dive into that, I'd encourage you to do that. But overall, it works for uncomplicated UTIs, essentially.
Okay.
Dosing is fairly simple. We mentioned taking it with food, but it's just 1 tab twice a day. You won't see this used widespread, and I don't think a lot of people are going to encounter this. If you go to the company website on this one, it's actually going to be exclusively available through Alto Pharmacy, which has limited sites across the country. There's like 4 in California, 3 in Texas, and a couple others scattered throughout the nation beyond that. But that's where it's going to be distributed through. So I think it's going to be pretty restricted. It's also very expensive. The AWP on a 5-day course is about $3,500. So It's very expensive. But I think it's good to bring up just so people are aware that if you hear of an oral carbapenem out there, this is technically a thiopenem antibiotic, but very similar to the carbapenems. And so it is out there, and we'll see where this evolves down the road if there ever is more data out there to use it as a step down therapy. But currently the data would not support that.
Yeah, I think it's important to highlight that, because if you were to just hear, oh, there's an oral penem, you might think, oh, I can do the step down, or I can, this would be an easy way to send someone home with. So yeah, great points.
And we'll see how our ID experts utilize this. I think that's where it'll probably be the main focus, though, is your ID experts that are dealing with highly resistant bacteria, and we'll see how they utilize it and then continue to research it, really.
Sure. Okay. All right. So that covers some infectious disease and UTI. So let's jump into the next one. I think we're going to get into medication for schizophrenia, right?
Yeah, so we got a new medication out for schizophrenia. Again, schizophrenia, a very common condition. The drug that is approved here is xanomeline, and so, but it's going to be combined with trospium and marketed under the name Cobenfy. And it's interesting because this drug actually, you talk about drugs in development for a while, there was actually I came across a trial that actually demonstrated efficacy of this medication that was published back in 2008.
Wow.
Yeah, so quite a while ago. So it's been in the pipeline for a while. But the issue was the GI side effects. And so why is there so much GI side effects with this medication? And it's because this works different than our other typical schizophrenia medications, right? We typically focus on medications that block dopamine receptors, specifically dopamine 2 receptors. That's kind of our backbone of schizophrenia treatments. But this one actually works as a muscarinic agonist. So it acts on a wide variety of muscarinic receptors, but specifically looking at M1 and M4 that tend to be decreased in schizophrenia. So there's been some research done there. And so the thought is by stimulating these receptors, we can help treat the symptoms of schizophrenia. So it's kind of fascinating that we have a completely different mechanism here to treat this disease state. Now, again, so the side effects were always the issue with this because you have muscarinic stimulation, you get a lot of that in the GI tract. You get a lot of GI side effects. So what they did was combine it with trospium, which is a peripheral muscarinic antagonist, to counteract all those GI side effects. Trospium won't cross the blood-brain barrier, so it won't impact the effects you'd be seeing on the muscarinic receptors in the brain. So
interesting. That's pretty innovative and novel. Like I like how they were thinking on that. That's interesting.
Yeah.
Okay.
And so from a kinetic standpoint, really the only thing you have to watch for is it doesn't need to be given with food because the trospium absorption is, it needs to be given on an empty stomach because the trospium is decreased with food. So you have to give this one on an empty stomach. And it's because of the trospium component being decreased with food. So just watch out for that. The contraindications and warnings really stem around, the muscarinic effects and the antagonistic effects you might get with the trospium. So urinary retention, decreased gastric motility, increased heart rate. Those are the types of things you just want to watch out for. So kind of think anti-muscarinic or anticholinergic, if you will, with the trospium part of that.
Okay.
Same thing with the side effects. It's basically GI side effects, nausea, dyspepsia, constipation, vomiting, those types of things we're seeing more commonly than the placebo arm. But we do avoid the dopamine side effects, such as all the extrapyramidal symptoms. We don't see the weight gain with this either. So it just has a very different side effect profile compared to our other agents we use for schizophrenia.
Oh, did they see a lot of the GI side effects still occurring when they made it the combo, or so it's still there? It doesn't completely get rid of it.
Exactly. Okay. That's a great point. So while it reduced it to the point where at least it's
tolerable.
Yeah, most patients could tolerate it, but they're still there. And you saw like 15 to 20% incidence rates. Again, a lot of them, how severe is that? It wasn't as severe as it was because prior to that, they realized you couldn't even go forward with it because of all the GI side effects by itself. But so it does help, but it doesn't eliminate them.
Got it. Okay. So again, key counseling point there would be to take it on an empty stomach because you want the trospium to be the one that's working for sure as well, so that you're not having terrible side effects. Okay.
Exactly. So take this 1 hour before or 2 hours after meals.
Got it. Okay.
As far as where it was studied, it was just studied against placebo. It did show it had a positive impact on both the positive and negative symptoms that you would see with schizophrenia. So, but again, no direct head-to-head trials that I've seen published comparing it to kind of some of our more traditional agents that we've always used. So,
okay. So as far as place in therapy, is this going to be just an alternative for those that don't like some of the other side effect profiles, or?
Exactly. I think it's going to be marketed that way. As far as if you're looking for a totally different mechanism here, avoid some of those side effects, some of those EPS concerns that some people have or maybe have experienced, then this does become an option, I think, is where we're going to see this. And so
that sometimes is a rate limiting factor for some people to take the medications. They don't want the weight gain, that kind of thing. So yeah. Okay.
Absolutely, and some people really struggle with some of that. So it's and it can be a reason to lead to non-compliance with some of the medication.
Exactly.
And so I think this is a nice addition to the market. We'll just see how it plays out in practice as far as how our providers and patients deem its effectiveness and side effect profile if it's tolerated. We'll see how that goes. It is a titrated medication as far as when you first start. There's going to be a starter pack where you start with a lower dose. And the idea there, I think, again, is those GI side effects, can they tolerate it? Sure. And then your titration is kind of based on, how much can you tolerate from a GI standpoint? And if you can, if you're not having issues, then they actually will step up in therapy and go up on the dose. But if not, you can back off a little bit too. And there's a lower dose that they can be maintained on, perhaps. So.
Got it. Okay. Yeah. Makes sense.
Yeah. It's expensive. Like any other new drugs, AWP is around a little over $2,000 for a 30-day supply. Unfortunately, a lot of our, some of our other psychiatric medications are expensive as well. This is right up there though. There's a copay card available though. And if you look at the company website, it says you can pay as little as $0 if you have the right type of insurance and copay card. So,
coverage,
so again, hopefully practitioners in that field, if this is in your area, you'll be navigating that a little bit to figure out if you can get it paid for.
Okay, that's great. So the next one looks like we're going to turn to it's gained some traction recently, or at least some attention as being a treatment for pain, and one of the first in several years that is a non-opioid treatment for pain, right?
Yeah, and I agree with you. I think this is the one I've probably had the most questions about from providers, and some of that's probably due to some marketing that's been going on too.
Sure.
But with suzetrigine is the name of the drug, going to be marketed under Journavx, and so this is a medication that's approved for moderate to severe acute pain. So again, a very common thing you'd encounter, right? And we have a lot of different medications we'll utilize for acute pain. A lot of them are opioids, but this is a non-opioid. This is actually a sodium channel inhibitor. And if you think of other sodium channel inhibitors that might be used for pain, even lidocaine comes to mind, right? But lidocaine is very non-selective as far as it hits a lot of different sodium channels. And this is actually specific for the sodium 1.8 channel. So it inhibits that specific sodium channel, which is just expressed in the peripheral sensory neurons. And so it'll block those action potentials in the periphery that will transmit those pain signals. And so that's how it would have its impact. Again, it's a non-opioid. There's no addiction potential that's been identified with this medication. So it's fairly clean from that standpoint, which is always a nice, certainly welcomed.
So we don't see any kind of controlled status, controlled
Nope.
classification for this. Okay.
Nope,
Okay.
it will not be, it is not labeled as a controlled substance. That's
Got
correct.
it. Okay.
As far as how, when you take this medication, food will delay the initial onset. So it's in decreasing those initial concentrations. So this is interesting in that you'll see that the first dose needs to be given without food. And then once you get those levels up with that initial loading dose, then after that, you can take it with or without food. It'll help, it'll maintain. But and the idea there is to get that onset on a little bit quicker. It's thought that from looking at the kinetic data in the onset, does it work as quick as an opioid? There's some question about that in some of that data. So, but just remember taking it without food will help with that onset of action. The Tmax is about 3 hours as far as time to max concentration with this medication.
Okay.
So that'll be an important thing to kind of remember if you're going to be using it, because from a side effect standpoint, it's actually very well tolerated. The side effects were very limited. They looked at common things like nausea and vomiting, which is common post-surgery, and that's really where they studied it, was post-surgery. They had a placebo arm, they had a hydrocodone and acetaminophen arm, and then they had the suzetrigine arm, and they actually showed the nausea and vomiting incidence actually even lower than placebo, and then and lower than hydrocodone and acetaminophen too. But as you'd kind of expect that, but it was actually fairly well tolerated even from a GI standpoint. So that's certainly welcome too. From an efficacy standpoint, I think that's where the question comes in: is how well is it going to work? The two trials where that you'll see in the labeling were for bunionectomies, so post-surgery for that, and then abdominoplasty. So kind of like termed as a kind of a so two surgeries that they'll look at these pain medications in. And
what was the first one you said, Joe?
A bunionectomy, so a bunion surgery.
Okay, that's what I thought you said. I was like, wait, do you mean like the removal of a bunion off your foot? Okay, yep. It sounds very specific. Why they would choose that?
It is, and I've seen other pain trials that have specifically looked at these two surgeries for whatever reason. I don't know.
Interesting. Okay.
Yeah. Yep. And so they looked at 3 different arms. They had placebo arm, they had the hydrocodone and acetaminophen arm, and with that dose, they looked at a 5/325 dose every 6 hours. And so again, kind of a fairly mild dose of that, right? I would say. Post-surgery. And then they had the suzetrigine arm, and then they could use the ibuprofen for breakthrough, basically. And if you look at the pain scores that they looked at over a 48-hour period, it was superior to placebo as far as pain reduction, and basically it was kind of an active comparator arm with the hydrocodone, but basically fairly similar is what they kind of determined. It wasn't deemed superior to hydrocodone by any means, but the overall numbers, if you look at the time frame and the kind of how the pain scores line up, is fairly similar to that. But again, keep in mind the dose of the hydrocodone acetaminophen was a 5/25 every 6, which again, it's just got to know what it was compared to, I guess. So
sure.
So it'd be interesting to see how this is utilized. As far as the dosing goes, it's oral only. And so again, they were looking at post-surgery patients, so you're given 100 milligrams up front and then 50 milligrams every 12 hours after that. Again, that first dose, it's going to be 2 tablets because it's going to come as 50 milligram tablets. So you take 2 of them for that first dose and then go down to 1 tab every 12 hours after that. Okay. But again, keep in mind that first dose needs to be given without food for try to get that onset on a little bit quicker. Right. It's fairly spendy. AWP is around $19 a tablet. So, okay. And the data that led to the approval, there was really no data beyond 14 days of use. So we'll see. It's meant for kind of these shorter acute pain syndromes. Yeah.
Okay. Do we think that well, I guess you just kind of answered that question. I was going to say, is this an alternative for, but I guess it could be like post-surgery, an alternative for those patients who do have addictive tendencies and want to stay away from an opioid? Like, do you think it's going to be a great option for them? Like, are we going to see it used in that fashion?
I think that's where it's going to be targeted. Now, The question is will it be perceived to work as well, and will it work as well? I don't have any direct experience with that, and so I think time will tell with that, right? Your surgeons that are going to be prescribing this and your patients are going to be giving feedback. But I think it's a very reasonable approach to take if you're trying to avoid opioids, which ideally, if you had a pain medication that worked, you could avoid opioids, that'd be fantastic, right? Yep. But it's just a matter of is it going to work as effectively, or will it be added on as kind of this multimodal post-op pain approach? We're starting to do a lot of that, right? And a lot of places are fully implemented these multimodal post-op pain approaches with using some of our other agents. And so will it be incorporated into that as well? So again, I think it'll be interesting to see how this plays out over time. This is also a drug class where I think we're going to see more specific inhibitors of these specific sodium channels research down the road. Now we'll see how many make it to market, but the thought here in reading some of the literature is that there could be others down the road that we might see with similar mechanisms, and we'll see if there's a clinical difference in them too. I don't, that's very preliminary. So.
Okay, so the trend could be that more drugs in a similar class working on a similar pathway then. Okay. Yeah.
And sometimes we'll see that, right? You get the first one to the market and then you'll see others come, but we'll see. I don't have a lot of hard data to support that yet, but in reading some of the literature, I think that it's kind of suggested
in that direction
to happen.
Okay. All right. Very interesting. Like I said, I know that's been one that's been heavily discussed and touted as being, not to play on words, but a game changer, and so I'm anxious to see kind of how that plays out. I'm hopeful. I hope that is an option and that we can, get more medications in a similar class to get away from using some of the opioids. So that's great.
That would be a deal in everyone's mind. And I know it's out there. They're marketing it. I was down in our hospice, office the other day, and they were asking about it, and there was some materials down there. So it is being marketed. So if you haven't heard about it already, you probably will soon.
You will. Okay. All right. Sounds great. All right. So let's move into our next one. And I lost my place, Joe. So tell me I scrolled my screen and I lost it. So tell me what's up next.
No worries at all. So berdazimer is the next drug that we'll talk about. And I think you pronounce the brand name Zelsuvmi, but it starts with a Z. But this is going to be a topical medication, and this approved for molluscum contagiosum in ages 1 year and older. So this is primarily a skin condition you'll see in pediatric patients. Okay. And it's basically a contagious condition. It's caused by the pox virus, but usually it's pretty benign, and most patients get over it on their own. It basically causes these small raised dimples with a little pit in the center that can kind of appear anywhere on the body, but they can itch. And if a child starts itching it, too aggressively, then you can get some breakdown of the skin, and then, that could potentially, you get an infection on top of it, and that would be kind of worst case scenario. But a lot of them will go away on their own. But there is a certain percentage in reading about this, about 30% are reported to still have bumps persist at like 18 months, and then depending on your immune system, it can even go longer than that. So some patients may get treated for this condition, but certainly not necessarily everybody. So definitely not one we're going to see
used a lot in practice, probably.
I don't think so. I think it's just good to be aware that it's out there.
Sure. Yeah.
It actually works by releasing nitric oxide. They'll say in the labeling the mechanism is unknown as far as exactly how this drug works for the pox virus, but in vitro there's data that it shows it blocks the replication of the pox virus, and so that's how it got the.
And it's a topical product, right?
It is a topical product, so you don't really have to worry about any kinetic issues with this one. There's minimal, systemic absorption there. The side effects you would see are mostly local. They reported, mild pain is probably being the most common side effect with the application. A little erythema, a little itching. I mean, the condition itself can cause itching, but there appears there's a little more itching even on top of this because compared to placebo, there, about 4% reported some mild itching with the application versus about 1% placebo. So perhaps there's just some localized effects. Mm-hmm. Again, most patients continued it and didn't have to stop it.
Okay.
So.
Okay.
From an efficacy standpoint, just briefly, it was studied against placebo. It can be used for up to 12 weeks is how it was studied. And they were looking at complete clearance rates of all the lesions, and there was about a 10 to 13% difference in complete clearance compared to placebo of all the lesions. There was some secondary outcomes looked at as far as even though it wasn't a complete clearance, did patients perceive a meaningful clearance? And a fair percentage actually perceived a meaningful clearance of those as well. So we'll see how efficacious it is once it gets into practice. If
sure.
I think your providers and your patients, again, we'll see how well it works. But it's simple, though. It's once a day to each lesion for 12 weeks. I mean, that's probably the most complicated part of it. You got to be persistent with it and do it on a daily basis. But it is once a day, so it's not like it's something that has to be done, multiple times a day. If you do dispense this, it comes in 2 different tubes. There's the active drug in one tube, and there's a hydrogel in another tube. And so there'll be a card that comes with the product that will indicate how much of each tube to put on the card to mix with your finger and then apply it to each lesion.
What?
Yeah.
That's wild. Okay.
It's a little different. So you just want to be aware if this shows up, you're just going to have to probably roll out the instructions a little bit and go through it with the patient because there's a process for doing that. And then after you apply it, it needs to dry for 10 minutes and then avoid washing that area for at least an hour after the application.
Interesting. So you said like a card and you squirt a little bit of each and then mix it up with your finger.
Yep. I haven't laid my hands on one, but it's supposedly there's 2 lines on the card that'll tell you put this much gel on, or cover the line with the active product, and cover the line with the gel right next to each other. Stir it together with your finger. Make sure it's good and mixed up. I think they say count to 20 is what is in the instructions. So 20 seconds, I guess, to make sure it's good before you apply it.
Interesting. Yeah, that's a first. I don't think I've heard of anything like that before.
Yeah, and it's expensive too. It's a 31 gram tube, and the AWP is $2,300 for it. So again, there's a patient assistance program, but it's on the website. It's going to be available through community pharmacies. They've listed some common community pharmacies as carrying this, or that will be carrying it.
Okay, so even more important at that price to make sure that we counsel properly on using that card and getting the exact amount so that they're not overusing it. So
exactly.
Yeah, for sure.
You don't want to be wasting this one.
Absolutely. Yeah. Okay.
Yeah.
Okay. Anything else on that one?
No, I think we're good to move on.
Looks like the next one is anemia.
Yeah, so our next product is known as Vadadustat. Vafseo, I think is how they're going to pronounce the brand name. And this is going to be used to treat anemia in patients that have been on dialysis for at least 3 months, so your chronic kidney disease patients.
Okay.
And this is actually the second drug in this class to be approved by the FDA. Daprodustat was approved back in, I think it was 2023. So I actually talked about a very similar drug a few years ago. But they've actually pulled daprodustat off the market, and I just don't think it ever really took off. And so the question when this one got approved is, okay, well, we have another one, we're approving it, but is this going to take off, or is it going to kind of not, kind of struggle a little bit like the other one? So we'll see. The mechanism is very similar. They basically work by increasing erythropoietin production. So it's an alternative way of increasing erythropoietin as opposed to just giving erythropoietin at dialysis sessions.
Okay.
And so it basically blocks the metabolism of some of these transcription factors, essentially, is what happens. And so and that process is downregulated in end-stage renal disease. And so we're basically kind of, you'll see it, you'll read about it causing like this pseudo-hypoxic condition. So it doesn't really cause hypoxia, but it makes the body kind of think it is. And so then it ups the transcription factors and to produce more erythropoietin.
Interesting.
So so it's kind of an interesting mechanism, but it's the well, why wouldn't you just give erythropoietin? And you could say, yeah, you could do that. This is basically an oral option. So
okay, that was going to be my question: was what's its hook? Like, because it just seems like there's the mainstay of just giving directly erythropoietin. So what is this one doing? Okay.
Yeah. It's just a little bit of a different mechanism to increase erythropoietin, but you're right. It's just the oral option essentially is what it is. It's interesting that, in the United States, these have only been approved in dialysis patients, but in Japan, there's actually 3 of these products that are approved in dialysis and reportedly in non-dialysis patients. So I could maybe understand the role there a little more, but the safety data that the FDA has reviewed for the non-dialysis patients, they did not deem it to be meeting some of the safety outcomes that they wanted, mainly from a cardiovascular standpoint. We know, like with erythropoietin, we keep an eye on hemoglobins and making sure we're increasing them too much or too fast. Of potential concern for things like MI, stroke, thromboembolism. Well, this is very similar. We don't want it to go up too much. We don't want to go up too fast. And so they've really required a lot of the data and scrutinized the data to make sure it's going to be safe.
Got it.
Before they'd approve it. And so they have not approved it in those non-dialysis patients as of yet. So
that was my next question, was why is it just for dialysis? Okay.
Yeah. It's just the safety signals in some of the trials they are concerned about. Because in the dialysis patients, this product in particular, they studied it against darbepoetin, and the safety signals were all very similar. There wasn't a real difference in a lot of the outcomes as far as the safety measures. So that's why they've deemed it to be as safe as darbepoetin anyway in the trials. And that's what led to the approval here.
Okay.
There is one drug interaction I want to note with this, because it's oral. If you give it with calcium or sevelamer or iron for that matter, it will decrease the absorption. So you have to separate it from those drugs. And I bring that up because your dialysis patients are generally on at least one of these, right? The calcium and sevelamer are commonly used as a phosphate binder in these end-stage renal disease patients on dialysis. Right. So that's a drug interaction. If you did opt to use this, you'd want to be aware of, because that's something that would commonly be encountered. So you just have to separate it out.
Okay. And then pricing, are we?
Yeah, it's expensive. It's 300 milligram tablets, which is where you start. The AWP is $1,500 a month. So it's once a day tablet. So it's not that complicated to take. And again, I don't know how the payment's going to work with this, with the dialysis payments and all that. I know when Deprotostat came out, they were talking about bundling it with that, but I don't know how that actually played out. Obviously, it didn't take off because it's not on the market anymore. But I don't know. I have not seen reports on how the payment will go for this. But if you work in the dialysis area, this is something to investigate and be aware of if your providers are going to be asking you about it. So, and again, is there an advantage of using an oral tablet once a day as opposed to just getting the erythropoietin at dialysis sessions? I don't really know that. I mean, you kind of assure compliance by giving the erythropoietin at dialysis as long as they show up for dialysis, right? But with the tablet form, you're going to be relying on them to take it once a day at home.
Okay. All right. Then looks like our final one is going to touch on dry eye disease.
Yeah, so we got a new eye drop out called Acoltramon. Triptyr is the brand name of this one. And so, approved for dry eye disease, which is actually fairly common. I actually looked up some stats on this, and they said estimated about 38 million people in the United States are impacted.
Yeah, we did a podcast on this recently, and I was shocked by the number of patients that have dry eye disease. So yeah, very common.
Yeah, and there's a number of agents out there used for it, eye drops. I talked to a couple of my optometrist colleagues that I know fairly well and asked them about it, and they hadn't really heard of it being used as of yet. but they commented on the other products that they like to use, cyclosporin. There's
Sure.
a couple other ones that, block tear evaporation and impact inflammation. There's also varenicline nasal spray. That's a cholinergic agent that actually used to increase tear production. I don't know if that's being used a whole lot either, but it seems like the patients that I see come into the hospital tend to be on cyclosporin drops fairly frequently. It's one of the more popular ones that's utilized. But I bring this one up because pharmacologically it's unique compared to the other products that are out there. And how this works is it serves as an agonist of transient receptor potential melanostatin 8 thermoreceptors. So I don't know if anyone will be able to memorize that. It works specifically in that field, but it's a mouthful. But essentially what it's doing is it's activating the trigeminal nerve signaling, which will increase basal tear production.
Okay.
So it's through a different mechanism. And so does that provide an advantage? I don't know. It supposedly provides a cooling sensation to the eye, and so I don't know if that'll be perceived as beneficial or not.
I was going to say, is that supposed to be a plus? I feel like that would be annoying.
it might be. In fact, in the reports, the adverse reactions, 50% of patients reported some sort of pain with instillation, but less than 1% actually stopped the drug because of any burning or stinging. So I don't know that it's. There must be some sort of mild pain, but not enough to stop the drug, at least in the trials.
Okay.
You do have to remove contact lenses before applying. So if contacts are pretty common. Sure. Again, with dry eyes, they may be avoiding them. But if you want to use your contacts, you have to remove them, apply the drop, but then 15 minutes later, you can reinsert the contacts if you want to use them.
Got it. Okay.
Little counseling point there. It did increase tear production, the primary against placebo, but the primary outcome was looking at 14 days, and that's where a lot of these drugs will be, say, it'll work as early as 14 days. This drug actually is, when you look at the marketing and labeling of it, it says it works as early as day 1. And so I could see it being marketed that way, that maybe it would work a little bit quicker than some of the other agents. Again, no head-to-head trial with other agents, so it's hard to make that claim directly comparing to something else, but you are going to see the marketing is saying it works as early as day 1.
Okay. All right. Anything else on that one?
The cost, I was going to mention just cost before we wrap up, because a lot of these agents in this class are expensive. Talking to one of our optometrists, said, a lot of them are over $600 a month. This one's AWP is around $1,000. So again, it's going to be pretty spendy, but it's one drop twice a day, so fairly easy to use. It comes as these individual single dose vials. So,
that was going to be my next question: is it a multi or a single? Okay.
Single, so it'll be pretty simple. There'll be cartons with multiple vials, or pouches with multiple vials in the pouch, I guess, is how it's going to be. So. Okay.
All right. Well, that's great, and looks like that's all we had time for. And but just as always, I feel like I just sit here like a sponge and learn so much. I don't know how many of these I'll ever see and hear about officially, but it's just interesting to hear the research that's going on and the new innovative pathways that they're finding to treat things. So yeah, very, very interesting. So Joe, as I always like to do at the end of an episode, is ask what the game changer is. So why is it important that we stay up to date? Just reiterate that, rephrase the importance of pharmacists staying up to date on new medications. So it's kind of restating the obvious, but I'll let you do it.
I think just so you can be a resource for not only your patients, but your providers, your colleagues and your friends. They're going to ask you about all these things. And so just to have good conversations about where some of these new medications might fit. And because there's a couple that you might see a niche for, right? I mean, a non-opioid pain medication, if it truly does have a positive impact on pain, that would be a great potential agent to be aware of. Even the xanomeline, from a schizophrenia standpoint, having a different side effect profile, just to be able to answer a question for a patient that's struggling maybe with some side effects.
Have an alternative option.
An alternative option, absolutely. And again, with all the direct-to-consumer advertising, it's interesting that a lot of our patients will watch commercials, right? And so they'll ask questions, and like you talked about that, and it's kind of fascinating that there's only 2 countries in the world that allow direct-to-consumer drug advertising, right? I mean, I think a lot of people are maybe aware of that, but some people might not be. It's us in New Zealand, I guess, are the only 2. But a lot of patients get some information that way. So when but they're still going to rely on pharmacists as the experts. And so it's good to stay up on these things so we can have a good conversation with them about these.
Well, and I think you brought up another great point, and that other providers may be asking our opinion and our expertise as well. And let's face it, we are the medication experts, so we should be up to date and be able to collaborate and answer questions and offer, again, solutions, alternatives. If they come to us with a problem patient of, I'm having XYZ issues and I need another alternative. So it's good to kind of know what's out there and just, like you said, at least whetting the appetite, and we can dig deeper if it's something that we come across, but at least we've now been made aware of them and heard of them. So yeah, super great. Well, Joe, thanks again. It's always a pleasure. Like I said, always learn so much and just really appreciate you giving us your time. So thank you.
Yeah, thank you for having me today.
Absolutely. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.